talk, I'm pretty sure as doctors, most of the listeners are, you would have known. I don't think I'm going to talk anything groundbreaking. What I will try and do though is put things into perspective. So I've changed the name slightly to COVID-19 in perspective, and I've taken that liberty, and I hope that's okay. But I think at the end of it, we will come to that, a brief picture of what we need to see. I'll try and share my couple of PowerPoint slides, and then we can go through that as we talk. And we can ask any questions at the end of it. I hope you can see my slides.
Yes, yes.
Yeah? Okay.
Yes.
So as I said, I've taken the liberty of changing the title to a COVID-19 perspective. Pretty much what we do is we look at what is available now, and I'm not going to go into the past, and we'll see what is there in terms of future and what the long-term outcomes of this disease may be. We can predict in a reasonably scientific way. Okay. The way I'm going to do this talk is we'll look at what COVID disease is at the moment in terms of the pandemic. Look at the disease, how it affects us, in the main syndromes and the main morbidity and mortality, the way it causes it, how we can manage them, what's the evidence base behind the management, and also the long-term outcome. So that's the parts of the talk. As you know, worldwide, this is shooting up, and as you know, the graph is climbing higher with more numbers, almost 45 million cases now worldwide. The death equally is also climbing higher. In terms of an Indian context, the hotspots now is this. In the last 14 days, if you look at the hotspots, the bigger the circle, the bigger the hotspots. So India, Europe, and the American continent, as we all know, are the current hotspots and an increased number of cases. In India itself, we rank second, only behind the United States, purely because we have such a number of population, and still we kind of managing it extremely well, I would have thought so. In the real terms, I think our peak is done, and I think we're slowing down slowly, which is a good news. That doesn't mean it's going to go away, but that is there. Our mortality rate, you can see 121,000 people have died so far nationally. We're just only behind US and Brazil in terms of mortality. So these numbers, and I'm pretty sure you're all familiar with the numbers, and in the media, it's almost like a scoreboard, like an Olympic match or something. In daily, we see the number of deaths, number of hospitalization, new cases, and etc. And that's a daily discussion. And that has a heavy toll on what we do and how we understand the disease. In terms of Kerala, where people have asked me to talk about, we look at the tiny state. It's been in the news, Kerala, pretty much for managing the disease extremely well in one end, and we have been before for Nipah as well, as you all know. We're doing extremely well in Kerala. The people of Kerala are doing extremely well. As you can see, the total number of cases as of end of October, and very few deaths, only 0.3%, though WHO expected rate of death is 1.5%. What we know so far is 98.5% will get better. Okay, and that's a key message of this thing. If you were looking at a disease, let's say cardiovascular disease or a primary lung pathology like COPD, if it is only 1.5% mortality, that's the best outcome of any disease. And 1.5% may die directly as a consequence of the disease. And those people who die are above the age of 50. Okay, young age death rate is extremely low. It's less than 1%. It's 0.25% or something like that. And those who die are with comorbidities. Diabetes, obesity, ischemic heart disease, or pre-existing lung conditions are the ones who die with the disease. So you're looking at a higher age group population with comorbidities are the people who actually are dying of the disease. Young people, that doesn't mean that young people don't die, but they are the largest group. From where we know nearly 20% will need hospitalization. This isn't the entire lot. The entire lot, those people who get COVID of 20. So if there's 10 people who gets COVID infection, 2 of them will need hospitalization, we think, approximately. And we know from WHO's prediction that nearly 60% of the population will need to be infected before the pandemic slows down. And that's with any pandemic. So this one being it, or SARS or MERS before this, and the influenza in 1920s. By the time it slows down in any pandemic, is about 60% needs. And if we then do the maths, in Kerala, just say this small state of Kerala, if it's 3.6 crores of people, at least 2 crores will need to be infected before the pandemic slows down. And of that 2 crores, nearly 30 lakh patients will need hospital care at any point in time. They will need a hospital care. And at a given time, if we then think at a given time, if 10% of the population gets infected, that will be 5 lakh hospitalization. And if that we think nearly 5% of them will end up with intensive care, we may need 24,000 intensive care beds. And we know from the estimate, from this year's estimate, the national estimates of beds around the country in India, Kerala has 98,000 hospital beds, nearly 100,000, and about 5,000 ITU beds. And this is where all these anxiety-driven policies and media come into the play. It is not the disease itself, the sheer volume of the disease, what matters, and the control of the resources that we have at our expense to look after people with the disease. It's not the sheer killing thing of the disease, but it's the volume of what affects it. And that's where we need to understand. So I think we need to take a step back before we kind of go into frenzy about this thing and think, okay, it's a small percentage being affected, but in the larger context. And that's where the resources are restricted. So with that kind of background, we look into what's currently available in our armory to kind of manage these people. Every one of us will have somebody we know with a severe COVID disease, and every one of us will have someone will have a mild COVID disease, which will get better over time. The management, as you know, for any infection is the antipathogen, which is the antiviral in this case, antiviral therapies. We all know the remdesivir and chloroquine and the anti-HIV drugs and ivermectin and all these kind of things. I probably won't be talking about those chloroquine and things because none of them has proven anything. I do get a lot of queries regarding the convalescent plasma and its use. There is no data to say that it works. There are case series where they said it works. We do not know actually is reality it works. The experience from Mayo Clinic is they've given almost 700 patients convalescent plasma over the COVID pandemic time, and the data doesn't show very promise that actually it is effective. So I'm not going to talk about that, so we can shut that. Mainly, I'm going to concentrate on the antiviral therapy, remdesivir, and the immunomodulatory therapies. So let's have a look at the remdesivir story. The remdesivir treatment for COVID-19 trial, which included about 1,114 patients, randomized into 2 groups, one that received remdesivir and then the placebo, 441 to 520. And they included everyone. The stats were done as an intention to treat population, which means they include the entire population, even those who missed in each group. So that was a good way of doing it. They classify the patients according to the scale, a severity scale, and this was your severity scale: no hospitalization, no limitations, not hospitalized, limitation, or whatever. So this is how they classified: hospitalized with and without oxygen. What they found was overall there was slight benefit in having remdesivir, not hugely significant, but there was slight benefit. For those patients who were receiving oxygen, there was hardly any difference. There was no difference having a remdesivir or not. Sorry, not receiving oxygen. Those who were receiving oxygen, there was slightly benefit of getting remdesivir. You can see the Kaplan-Meier graph is slightly diverging off. But those who were in high flow oxygen or mechanical ventilation, they were literally on the top of each other. So there was no benefit at all. So this is the only group who had some benefit, if you may say, in this trial. People receiving oxygen, severe enough disease that they're receiving oxygen, and they benefited. And if you look at the recovery according to subgroups, we can forget it. Let's forget about this. All the ethnic diversity. If you look young age population, so the more you go to this side, the right side is better outcome. So less than 40 years had better outcome. Now that can be interpreted in different ways. You can look at young patients anyway get less severe illness, and they actually get better anyway, and the mortality has been less. So maybe that's affected this result. We do not know. But those patients who not receiving oxygen, the odds ratio is only, recovery ratio is 1.29%. So but when you receive oxygen, it's slightly more better. But when you're on ECMO or mechanical ventilation, it's towards this line. It's not that significant statistically. So this is the group that by and large that really benefit if you're young and has a severe disease enough to be on oxygen. Secondary outcomes, as you can see, the rate ratios all in minuses. It's not really significant. None of the secondary outcomes like the duration of the oxygen needing, how the duration of median days of high flow oxygen, mechanical ventilation or hospitalization and to discharge, nothing really changed. So that was unaffected. The study has its limitation. The problem was it was given to a wide variety of patients, and the study was not powered enough or designed to detect difference between the groups of patients. Like, for example, it didn't compare properly. It was just given to anyone from mild disease to severe disease. It didn't design to compare with mechanical ventilation versus non-mechanical ventilation or severe versus mild. It just gave everyone. It wasn't designed to do that, and statistically not designed enough to powered enough to do that. So we do not know what the real outcome of that would be, subgroup. The study was powered to detect difference in clinical improvement and not mortality either. So the primary outcome of that was clinical improvement, not mortality. And the long-term morbidity was not collected either. So that was a limitation of that study. And then you have a randomized double-blind study, the multi-center study, where 255 patients were there, and 158 to the remdesivir and 179 to the placebo group. Okay, and they didn't do intention to treat analysis, but instead they actually included 150 to the protocol and 76, so a couple of withdrawals and didn't get the treatment. Again, it did slightly better in terms of getting out of the patient, the cumulative improvement, but if you look at the viral clearance, it was not different from the start. Viral load and the viral clearance was not any different, but they did get better slightly compared to the control group, and that was a smaller study. The problem with that study, this was the first study actually done in China. The problem with the study is, if you look back, the study was designed on power 2. To get a meaningful answer, they needed 650 participants in the study, 325 in each, to get an 80% recruitment target with the type 1 error of 2.5%, which is when your study becomes meaningful. However, they ended up terminating the study early because of the problems in the Wuhan and the shutdown and everything. They couldn't do it. And the sample size didn't get, I think they closed at 60% recruitment, nearly 60% of the recruitment target, which then means your study is pretty much useless, pretty much. It becomes a glorified case series. So this study really, you can only see as a glorified case series. You can't see as a proper RCT because they didn't achieve what they set out to achieve. So even though they slightly showed better in terms of discharge, early discharge from the hospital, but no other benefit in the outcome. Then we have a remdesivir trial giving for 5 days versus 10 days in severe COVID patients. So patients with severe disease, hypoxic, they gave 5 days treatment versus 10 days. Okay, and this was published in New England Journal. 200 patients roughly in each arm that got either 10 days or 5 days of remdesivir, same dose. No difference whatsoever between 5 days and 10 days. So if you look at the clinical improvement, it is all the baseline adjusted difference is all in minuses. It's no different. Recovery was not different, and the modified patients is also not recovered, no different. So out of 402 randomized, the problem with that study was at the baseline, the 10-day group actually had a worse clinical status than those in the 5-day group. So the two groups were not very similar. So one was a severe group and the other wasn't as much. They did stats to balance it out, so it didn't become significant. But however, when you look at the result, the time to achieve clinical improvement was similar at 5 and 10 days. Median duration of hospitalization among the patients who were discharged was similar too, at day 14, between the 5 and 10 day. Serious adverse events were more common in 10-day group than in 5-day group. That is about 35% versus 21%. So if you give a longer thing, it turned out that they had more adverse events. But we need to be careful when you read into that. There was baseline imbalances of both groups. And also in severe group, they were not only on remdesivir, they were also on other treatment like anti-HIV drugs. So whether the side effects were just because of remdesivir or the combination of other management strategies, and they all had severe disease, we do not know. So that's not very clear from the study. And then there is this trial in JAMA where they had 612 patients. This went into 3 arms. They gave for 5 days, 10 days, as well as a control group. So almost 200 in each arm. And they also did an intention treatment analysis, and this was largely the outcome. So they gave 10-day remdesivir IV, and 5 days and then standard care. The main findings were the difference in the primary outcome indicators was day 11 at 5-day group had significant improvement in terms of clinical improvement. But the 10-day courses, there was no difference between in the clinical outcome. So if you look at it again, it's mainly the day 28, there were more hospital discharges among both groups. Okay, but at day 11 it wasn't. So the longer you went, they both had better outcome in terms of discharge, 89 to 90%, compared to those who got the standard care. Mortality was low in all groups. There was not difference. And adverse event, again, were treated with remdesivir among those who received standard care, nausea 10%, and hypokalemia and headache. So they had side effects more in the 10-day group. Again, this is an open label design, not randomized controlled properly trial. Compared to remdesivir groups, a greater proportion of the participants had hydroxychloroquine and the HIV drugs and azithromycin. So whether the combination of this caused the problems, we do not know. Same problem with the design. In summary, all we can say now is remdesivir in patients who require oxygen may improve with severe disease. Who do not benefit in severe disease, like high flow nasal oxygen or mechanical ventilation, there's no benefits shown so far in any studies. There's more kind of modest improvement. It's not a massively striking statistical differences between discharge and clinical improvement, but it's only a modest improvement. It is there, we think. However, no real data shows improvement in viral load clearing or mortality benefit or reduction in mechanical ventilation, requiring mechanical ventilation. We haven't got any evidence for that. So the only use is patients you think who, especially in the younger group, who requires oxygen, but not enough to require high flow of mechanical ventilation, will benefit from that antiviral. The second is immunomodulatory therapies. Now, this has picked up a huge interest. And it comes down because of the immune system and how it works. So what I'll do is, before I go into the immunomodulatory therapies, I'll talk about how the COVID virus actually triggers an immune response and how that affects us in a brief couple of slides. So basically, the cytokine syndrome, we know the disease severity and mortality is related to hyperinflammatory in SARS-CoV. That feeling had been from the very beginning from Wuhan when the stories started to come out. We all thought, okay, it's very similar to SARS virus. It's causing a hyperinflammatory response and causing the tissue damage. As you all know, the cytokine storm is an umbrella term. We've all seen this in different infection settings, from streptococcal infection to influenza to multiple viral infections, EBV, HLH, and we even know familial HLH, juvenile arthritis and the macrophage activation syndrome and all that thing. We've seen this cytokine storm in different contexts. The oncologist in lymphoma leukemia treatment, we've seen cytokine and all the different settings. We used to call HLH-like syndrome in the beginning when the COVID started with these patients. We now know that in some people, a lot of others have tried categorizing into stages. I do not know whether people fit into these boxes. They don't always fit into boxes, but this is a nice thing to think about about COVID. When you think about COVID, you probably need to think about it in stages, especially most patients who end up in the hospital. So The stage 1, when you've got a high viral load, the viral phase response is mainly when you get clinical symptoms and signs. You get mild constitutional symptoms, fever, aches and pains, tiredness, and you may also have a lymphopenia. And then you start to get better. Fever settles. Things start to settle. 3 to 4 days, they may get better. And then some people will have an inflammatory response phase, which will start. And then they start getting unwell again with this inflammatory phase. And this is when they end up in hypoxic with COVID pneumonia, like changes, infiltrations in the lung, X-ray changes and CT scan changes that you all see, hypoxic with a high work of breathing and all the complications that we see. And then towards the end, they may end up with an ARDS-like picture, shock and cardiac failure, with the raised CRP, LDH, D-dimers, ferritin, and etc. What are the features that is similar in terms of COVID to the cytokine HLH that we know? So the HLH criteria that we know may have all these, not all of them, but most of them. Fever can have splenomegaly, anemia, thrombocytopenia. But in COVID, fever is, yes, universally we have a toxic fever, and unremitting fever, especially after that 7 to 10 days, is the most important thing that you need to look out for, seeing they may be switching into a hyperinflammatory phenotype. Anemia is they can be slightly anemic, thrombocytopenic, and neutropenia can be a feature of it. And more importantly, I would really like to point out to the hyperferritinemia. And I think the talks I've been giving so far, I've been asking people to actually concentrate on the CRP and the ferritin levels. Just like the HLH, ferritin also shoots up more than in thousands, really, and falling ESR. So these things really will tell you the phenotype, especially with the clinical picture, the space changing from having the infection, getting better, and then having an inflammatory response. And you look at them, they'll have lymphopenia, anemia, thrombocytopenia, a bit of neutropenia, fever, and that toxic features, and the hyperferritinemia. And that should trigger your thoughts. Okay, the cytokines are actually quite high. It's a complex interaction, as you can see. Most cytokines does lots of things, DIC to decrease serum protein, to kind of debilitating illness, tiredness, etc. A lot of centers measures IL-6, and I'm pretty sure in India, a lot of centers do measure IL-6 as well. One of the problems with IL-6 levels is they're not really reliable, because even without a cytokine storm or the cytokine syndrome that we see in COVID, your IL-6 levels can be raised. It only means that you're actually, macrophages are breaking down and neutrophils are breaking down, and you tend to release IL-6 levels. They may not be because of the cytokine storm and the cytokine toxicity that you see as a part of this illness. So IL-6 levels are really not a reliable way of actually to think about treatment. It actually should be clinical, and the previous slide that I showed you. And there's a lot of debate whether we should use cytokine storm syndrome or hyperinflammatory state in COVID-19. I'd rather prefer hyperinflammatory state myself, because it is different from HLH, and the pathway of inflammatory response is also slightly different. Okay, it may help us to categorize patients, and I think this is where we need to really think how to categorize these patients who come to you very sick. So we know when we look at the viral infection, the response to viral infection, okay, we all know if you get a viral infection, you have an early innate response. Your monocytes, the natural killing cells and cytokines, they attack, and then your cellular immunity picks up and then helps the viral clearance, and the viral load goes down, and you're better. This is how we all get better from common flu, the common coronavirus infections that we get. We all get better. This is the mechanism. But however, if you have overwhelming viral infections, sometimes when we end up with the ARDS and things like that we've seen in the past, with influenza patients die every year, but influenza, with sometimes we die with HLH. This is the mechanism. So you get an innate response that never settles. You end up with cytotoxin toxicity. Your viral load is high. Your adaptive response, it kind of gets tired and give up almost. And that's when you start getting lymphopenia, immunosuppression, and then you get secondary bacterial infection and etc., ARDS, and then you end up dying. Okay, and that's the usual course with the uncontrolled viral infection and chronic infection. This is roughly what happens in COVID-19, we think. Okay, so when we have an overwhelming infection where we've switched to an inflammatory phase, we get this innate response. So this is where the physicians around the world has been targeting treatment. So we're trying to block the IL-6 and IL-1, which is where the receptors, they say the IL-6 and IL-1 blocked with anti-receptor antagonists like tazolizumab or sarilumab, things like that. Or we try and hit the corticosteroid. With the corticosteroids, we try and hit the cellular immunity, so effective cells, so we can dampen down that response and improve T cell function and continue with that to fight the disease. And this is where we've been trying to hit it. Antivirals and convalescent plasma and everything comes there. Even monoclonal antibodies. And then we think about IL-1 especially is picked up a lot of interest. The IL-1 cells, again, are released by COVID-19 levels. We can't do measuring assays like we do IL-6 because it's quite difficult to do. They are also produced by macrophages and neutrophils. We think they play a very critical role in the early pathogenesis. And it may also be responsible for increased thrombosis. That's what we think. Okay. So if you follow the common pathways, the SARS-CoV gets attached to the AT2 cells and the epithelial cells in the alveoli. They trigger the macrophages, and they tend to release both or all of these kind of cytokines, which then triggers a Th1 and Th2 mediated response and a cytokine storm. Okay, and we think this promotes the disease severity, and that's the treatment rationale. Okay, so we all know of recovery trial, one of the largest trial in history of medicine, probably in the shortest time ever done. Thousands of patients have been recruited. So this is about dexamethasone where we come. Okay, so patients admitted to hospital proven as SARS-CoV-2, so they need to be hospitalized, randomized into different arms. These arms have been published now. They don't no effect. We'll talk about the dexamethasone. Okay, all-cause death is a primary endpoint, and secondary endpoints are duration and hospitalization. So if you look at them, patients who did not receive any oxygen, okay, usual care, the favor towards usual care. Dexamethasone didn't do any good. Okay, so those who had oxygen as well as invasive mechanical ventilation, having dexamethasone on board fared extremely well. So they did really well, and that was the outcome. And this is so far the best data out there for use of steroids as an immunomodulatory thing. And then we look at steroids and the impact on mortality and need for mechanical ventilation. This study was published. This was an observational study of 1,800 patients they included, of which 140 received glucocorticoids. Okay, if you look at the CRP levels and the odds ratio, those who had CRP less than 10, when they were given steroids, they were twice likely dying or increased mortality, twice increased mortality compared to standard group. When they had CRP between 10 and 20, it didn't make any difference. So, but those who had higher CRP, in other words, inflammatory response, hyperinflammatory state, they had much better outcome. The outcome was, odds ratio was less than, was 0.23%. So when you have an inflammatory switch, your outcome is better. So we need to think about putting everyone on steroids. So patients who doesn't have any inflammatory response, you're probably doing a disservice by giving them steroids. So you really need to categorize the patient and think who you need to give them. So the next one is the anti-IL-6 therapy, which is the tazolizumab, which is what a lot of centers use, and that's lots of use around the world. It started being used as an off-license thing, but still people are using it. And the rationale is what I showed you before. So this is a prospective series of 100 patients with COVID-19 pneumonia and ARDS with ventilator support. The tazolizumab use 8 milligram per kilogram, and they give maximum dose of 8 milligram in 2 doses, 12 hours apart. The third dose was given as an optional based on the clinician's discretion. So patients who were in ICU as well as general ward, they both improved basically on tazolizumab. But remember, this is a case series and not an RCT. The same again was repeated in a prospective series of 85 patients. again with severe pneumonia, respiratory failure or not ventilated. They were given single dose of tezolizumab instead of 2 doses. It was a lower dose of tezolizumab. And they fared better. As you can see, the control group actually got worse. So it was effective, and hence everyone started using it. However, there is now an unpublished data that National Institute of Health Sciences in the United States says they don't recommend using IL-6. I haven't seen the data myself, but on their website they published there is 2 unpublished data, one using siltuximab and one using tezolizumab. The siltuximab data is almost 1,900 patients or so, and tezolizumab is also a very large data. There is no benefit. Those are RCTs. There's no benefit. The problem with the case series studies, the 2 I showed you, and there are 2 more, I think, the positive studies they're all heterogeneous. They've used different methodologies. You can see twice daily dosage, patients whose severity was differently described, and patients were not really categorized according to the inflammatory response. The enrollment criteria was different, and they had lack of stratification. So we really do not know which patient actually had a proper inflammatory response and things like that in this group. So we do not know the outcome. The RCTs, they say there is no benefit. Yet to be published. I think the data was closed in October, so we will see the data in the next 2 months out there. Then is the next kid on the block is the anti-IL-1 therapy. Okay. So this is again case series. So beware, it's a retrospective analysis. They had 10 patients, bilateral pneumonia with COVID, hyperinflammation, respiratory failure, not ventilated. Yeah, and they treated all of them with canakinumab. Basically, the CRP, the inflammatory response, did improve after 7 days. This is a control group which kept going. Okay, and so that's where the IL-1 therapy came. And in actual fact, where I work, we use more IL-1 and anakinra than compared to tezolizumab, purely because the side effects is much less. As you know, anakinra is also an endogenous thing, and half-life is much smaller. Tezolizumab also can give us a false assurance that the CRP actually gets better because it mechanistically can inhibit CRP. It may not be switching off your inflammatory response, but it can reduce your CRP on its own. So we have used anakinra more than tezolizumab in our center. In terms of this case series, had 11 patients, again with hyperinflammation, ferritin more than 1,000 was an inclusion criteria, and patients who require high flow oxygen, basically. As you can see among these 11 patients, these are all each patient. Their ferritin level came down, lymphocytes really creep back up to normal, and CRP fall down as well over 2 weeks. So that was about 11 patient case series. So those are the immunomodulatory therapies. And then we come to the discussion of vaccine. I won't spend much time on this one, but I think what we need to think about the perspective of vaccine. And I can see if you read media now, vaccine is the biggest discussion. We're all waiting for this magic bullet to come through. What we need to think, like any other disease, okay, we need to think our antibody response and how this works. We know from past coronavirus, the normal coronavirus infections that we all had, like common cold and things like that, average duration of coronavirus antibodies is about 52 days, and it doesn't last that long. So we need to think, unlike some of the diseases that we have antibody response lifelong, it doesn't. Influenza, you know, is 6 to 12 months maximum. That's why we give yearly. And coronavirus, this COVID-2, we do not know how long it's going to last. What we know so far is the seroconversion takes about 2 weeks for IgM and IgG to come. In less than 40%, it can be within 1 week of the symptom. It goes up to 100% after 15 days, both IgG and IgM. IgG less so, but IgM. Okay, the mild case, we know for certain mild cases take longer time, and sometimes they do not at all have any antibody response. We do not know how long these antibodies will last. And we know for certain now, there's more and more reports coming out about reinfection, and some reports have claimed reinfection in as little as 80 days. So it goes up, we do not know how long it's going to last, and we do not know the response. So this flies on the face of vaccine. So we know a lot of vaccine, more than 70 or so vaccines are in preparation. A couple of them are actually due to be released which is an unprecedented speed. We know in the past, a vaccine manufacture means it takes about 10 to 15 years on an average. Now we have latest methods of doing it, not in the old-fashioned way we did it. That sped up a lot, but also a lot of the political pressure, things have been sped up hugely. What we don't know is, if you give this vaccine, how long it's going to last. The Oxford vaccine trial, the first dose was given in June this year. If you think about it, they want to, the last serum analysis will be a year. It'll be next June, 21 June, till we know how long that antibody lasted, if we did have an antibody response. And if you think about the number of patients they need to recruit for the trial, by the time, at least if they finish recruitment in 3 to 4 months, the 4th month patient will be in October. That patient's last serum test will be next October, 12 months. And then to analyze the result and get it for mass production, it'll be 2022 we're looking at. We can bypass that with political pressure, maybe, and maybe we can do an interim analysis at 50% in midway. That will be 2021. And then to have a mass production and get this vaccine all over the world, I think it's too much a bit of an ambition. I do not know, maybe things happen, but I don't think as a scientific thing community, I think we shouldn't expect much from there. This is good for political stunt, but I think reality doesn't work as such. Then everyone will think about the monoclonal antibodies. With Trump having COVID and the Regeneron came into big time in the news, these are the phase 2-3 monoclonal antibodies that is going on with the trial and showing some promise in terms of getting better. They have, the Lilly group have published their preliminary report in New England Journal, which shows a slight benefit again in terms of clinical improvement, but the Lilly one has been stopped now because the side effects profile has come to the pre-decided threshold. So patients are getting side effects and they're really looking at things now to proceed with the further trial. The Regeneron looks promising. It's in phase 2-3. Before we get it, we'll see the results. We haven't got any data on that yet. This is the current management strategies. Now, what about long-term effects of COVID-19, having COVID-19? Okay, so I'll tell you a couple of cases that I've come across. So this is a patient I've seen in the clinic who had COVID. This is the patient, this is the x-ray when he was admitted, and this is his discharge x-ray. Well, not discharge x-ray, when I saw him in the clinic after discharge. 2 weeks after his fever and cough settled, he got better. He started getting chest tightness and breathlessness. This is what he said when I saw him. We did a 6-minute walk test in the clinic. He was desaturating from 98 to 92%. Did a lung function, which is volumes were pretty normal. His gas transfer was quite reduced, 44%, very reduced. Echo was normal. Bloods, his ferritin was slightly on the higher side, about 400. CRP was 20. Did an ultrasound. He had abnormal lung on both sides. So we did a CT scan. This is 2 months after the index infection. So you can see huge amount of ground glass changes. They still got inflammatory changes. This is about 2 months later, covering the entire of his lung. So this is 2 months after his infection. And the patient was a 61-year-old, very healthy and fit. He was a professor of arts in one of the colleges in London. He used to cycle to work every day, about 20 miles from home to work and back. He had a COVID infection, became extremely unwell, was admitted to hospital. He was peri-intubation, was hypoxic, needed about 40% FiO2. Didn't get intubated though. He got better slowly and was discharged home. By the time he saw me in the clinic, he was walking 5 kilometers, fine, starting to cycle slowly again, and he was completely asymptomatic. That was his admission x-ray, and this is x-ray when I saw him. His 6-minute walk test again, he was desaturating. So did the ultrasound again, and it was on, the B lines all over, and it was abnormal. Echo was normal, his bloods were normal, CRP was 2, and D-dimers were normal. And this is a CT scan. And again, you can see the same thing. Ground glass changes around the periphery. Not as severe as the previous one, but he does have changes. If you look at, he's got kind of some atelectasis changes and also still a lot of ground glassy changes. This is another patient, a 70-year-old. I've been managing this patient from a distance from in another country. He's previously fully healthy, absolutely fine, no comorbidities. He's only on amlodipine, started about 2 months back, had confirmed COVID-19, was really unwell, admitted to ITU, managed with CPAP, dexamethasone, and remdesivir. He was discharged after 4 weeks of hospital stay, was on oxygen about later. He is now off the oxygen, but still hypoxic on exertion. He has exercise tolerance limited to about 5 meters, and his CT scan after about 2 months. And this is his CT scan. As you can see, got extensive consolidation, lots of ground glass changes, very dilated airways, contraction bronchial dilatation. If you look at these, you can see the airways is severely dilated, which always means you're developing interstitial fibrosis. Yeah, and you can see again here traction bronchial dilatation and quite a lot of consolidation, and he is developing good amount of fibrosis. I continued with steroids in him, and this is him end of October with about 2 months of steroids now by the time. Even those part of the CT scan here, if you look at these scans, you almost think these are established fibrosis. But by the time 3 months of steroids, even those are becoming softer and melting away. And much of his traction bronchial dilatation is resolving too. And this is not the first patient I've seen like this. And I think there are patients who look really severe, but if you treat them, they do get better. Now, this is not uncommon. We are seeing in our center, when we looked at about nearly 400 or more patients, nearly 30% had this pattern. This is not soon after the infection. This is about 2 months later after the hospital admission. Not mild disease. Those who needed hospital admission and oxygen, you bring them back and they have this problem. If you look at the literature there, in SARS epidemic in 2003, nearly 8,000 patients died, had a 900 something died, and MERS the same thing. As the data from the Canadian group, about 15-year follow-up showed persistent interstitial abnormalities and functional decline over the first 2 years, and then remained stable. So they had similar changes. They had interstitial lung disease, and they got better. They declined over 2 years, but they stayed put. Maybe because the cytokine toxicity kind of played until then and then got better because the antigen is gone. The MERS also had same thing, but there is no long-term report on the MERS. But nearly 30% of that patient group also had exactly the same thing, interstitial lung disease. They functionally declined, get reduced gas transfers, but they kind of stayed put after a while. And the next thing is the COVID-19 in the media. You know this has been going on, from Trump asking us to drink bleach, to having chlorine dioxide, to people drinking alcohol gel that's for hand cleaning, etc., to try and get rid of COVID in the media. I was just looking into the effect of media and the infodemic, as it's called in the Nature magazine journal. They call this thing as an infodemic. They looked at people actually going, so cumulative responses, number of responses, and the question scores. Yeah, it steadily increased during the pandemic period. And questions as this, the bottom line is the reliable sources, and this line is the unreliable sources. And the response to those discussions also increased proportionally. So people are being affected by this infodemic in the social media hugely, and people are more and more getting engaged. And you can see this is the growth of number of authors over time as well. They're also steadily climbing in the same literature. This is massive increase. And what does this have a psychological impact? This is impact on the society as such in the large being. One study showed a survey in the North American population. They showed nearly 50% have moderate to severe psychological impact. Of that, 16% had severe depression, and nearly 30% had severe anxiety. This is high among the younger age group patients. And almost 50% of recovered patients have high level of anxiety. And also in that study, nearly 25% of those recovered patients had genuine neurological impact as well. And we see this time and time again. And I know from experience, You see patients sometimes with really good going COVID pneumonia, very breathless, high work of breathing, but they're completely asymptomatic. And I think that shows the neurotropism of COVID-19. And I think there is an effect this causes on our brain. It depresses our senses, changes the way we do things and understand things. And I think that neurotropism is clear, and it's definitely an impact. But more so, the social media and the general impact on this disease is real, almost like a post-traumatic stress disorder. So I think we're going to see a lot of this in the community. If you look at the future of COVID-19 in terms of management, if you just look at clinicaltrials.gov and put COVID-19 trials, you would see at least 351 active trials. Of that, 291 is pharmacological trials. Newer antivirals, immunomodulators, etc. Okay. The most interesting ones are these ones. People are already using GMC as a blockade and anti-JAK things. It's an anti-JAK inhibition. The target was used by several pro-inflammatory cytokines. Okay, patient with moderate COVID-19 pneumonia, they gave baricitinib for 2 weeks with a control and used the historical control group as a control in the control arm. And the results with the showed fewer ICU transfers, but this is only in 12 patients. Okay, but they've used it successfully, and apparently it works. There's more data and study going on that. And there's another study looking at the GMC as a blockade by giving this drug for 13 patients. And again, if you look at the graph, they got better, and these patients, the patients who didn't have the control group, declined over time. But this was patients with severe pneumonia. So there are newer things coming out, more in terms of immunomodulation, and there are some antiviral drugs, that new molecules that they think may work. And I think more than the vaccine, the future is understanding the disease properly first. We're able to characterize those who have severe disease. And also we need to understand better drug dosing, like if you're using anti-IL-6 or anti-IL-1, when to use it, how to use it, what kind of short life drugs we should be using. Steroids, dexamethasone 6 milligram once a day, is that enough for every severity? Do we have to pulse them and hit hard? That kind of thought process needs to happen. Until we have clarity on that, I think management of COVID-19 for the future, we have to move away from individual management to a more collaborative management between specialties, like intensive care with respiratory medicine, with rheumatology specialists. Especially the rheumatologists are very important in this thing, because they have a huge role and they have a huge experience in anti-cytokine antibodies and immunosuppression, and they should also be a big part of the team. So this should be a collaborative management, and I think that's a better way of looking at things. The takeaway message is this is not a disease to be frightened of, and I think that's very, very, very key thing. Only 1.8%, 1.5% death rate. We're only seeing this too many because this is the volume. In a year or two, this will settle down, and then like influenza killing, in UK, influenza kills about 5,000 to 8,000 patients a year, especially the elderly. In America, it's about 30,000 a year because of higher population. COVID-19 will be with us for the future. And we need to think, okay, how are we going to deal with that? And patients who get the cytokine syndrome, how are we going to deal with that? And we have to have a collaborative approach and think of it. But 95% or 98% won't have any problems. It's a new disease in a pandemic, and the volume, as I said, this can put a strain on resources of any country, and that's where the importance now is. Okay, for future, it's not the case. And determination of the optimal time to manage and intervene, and patient selection will be the important determination of the outcome for the long run. That's what we need to concentrate on. And bear in mind, it's not only lungs that COVID-19 can damage. Myocarditis is not uncommon. We see that really commonly, sometimes, especially severe end of the spectrum. I've had a colleague who had GI perforation with COVID-19 and did very badly. So that's a real thing. So it can affect other organs, and we need to be mindful of that. It's coming out. Patient with a hyperinflammatory inflammation should have timely targeted therapy. So we need to think about targeted therapy. And there is no one box fits all. So we really need to think about CRP ferritin, who needs oxygen demand, the work of breathing, cardiac function, and we also need to consider thromboembolic disease and seriously in this patient group. And I think as physicians, there is a responsibility between us, and I think we have to think how we behave with the social media age, what kind of information actually we go give people, the general public, and we have to take the ownership of educating the public from the media. The media frenzy is too bad, and I think we should take the ownership from the media, write articles, educate the public to bring the scare down and give them psychological support. Inpatient care is one thing that shouldn't stop with that. I think that there's long-term effects. We will see a lot of patients with long-term effects. And vaccine is not the answer. That's only one part of the treatment option. We don't think we will have a vaccine that can last lifelong. Even if it is successful, it'll be a short-term one, and COVID-19 will still be there. So we need to think about our treatment options. With that, I think I'll conclude the talk and happy to take questions.
Thank you, Dr. Liju, for the lucid and comprehensive perspective on COVID. We have crossed 1 hour, and you can see a lot of questions in the chat box. I think you can just read up. So let me start with as a chest physician and the general population also, we are more concerned about reinfection, which some of the questions in the chat box are about. How frequent are reinfections? And since you are facing the second wave too in your part of the globe, how frequently do you see reinfections? And second thing, as a chest physician, again, we are seeing, probably personally, I'm seeing around at least 2 post-COVID symptoms in my OPD every day. So something on that.
So Dr. Bashir, it's a difficult thing because there is no data of reinfection at the moment. There's only case series coming out. So I can't put a number to it. But like as I said, there are small data saying the antibody clearance happens around 3 to 6 months. 3 months in some data from King's College, there was a data they took out all the blood serum that is in the laboratory and looked at the series of serum they had on the same patients. And in some patients, the antibody completely cleared in 3 months' time, and that usually is in mild disease, especially. So, but we do not know the numbers in large numbers. We do not know how many patients get reinfection. So, reinfection, however, there's a real risk of it because we know the antibody is not a lifelong thing and it can clear quickly. So, it's a real risk. So, we do not know the numbers. The second thing about the post-COVID syndrome, again, our hospital is, we've done the data. In our experience, we saw the first wave, we saw about 1,500 patients who were hospitalized. We called back around 460 patients or so. In that, about 28% had post-COVID pneumonitis, which is about 2 months later after the infection. The data is given to be published and hopefully it will come up soon for you all to read. But that's real. And if you look at the SARS and MERS data, they have the same thing. It's the same virus, obviously the SARS virus. But again, we expect the same thing at about 30%, that's going to be a pneumonitis. The key thing is, how do we preserve normal lung as much as we can? And I think that's where the importance of this thing is. So for the volume of patients getting admitted in the hospital, you will see a lot more. If we ignore them, there may be a group of patients who will be debilitated for life. And that's the importance of that.
Okay, for the information of the audience, we do have researchers, we do have clinicians, and so we are lucky today to have 2 in 1. We have Dr. Liju, who is a clinician as well as into research. So my question, as from India, when we buy cars, we are concerned about the mileage, and also in treatment aspect, we are concerned about the cost. So I don't know if you have read about that. We have a lot of researches coming upon ivermectin and doxycycline in managing mild to moderate cases, and many studies are highly said to be highly promising. And also regarding methotrexate, which is also a cheaper drug, which is a cheaper interleukin blocker. So what's your view on those?
So again, Bashir, like you said, I'm a clinical academic. There are lots of clinical academics, and I think you all are clinical academics. We are trained like that. We are trained to look at things in a way, like unlike other things, because it's science, we have to understand what works and what doesn't work. The key thing about this data is, like you said, yes, people have to try based on the science, knowing how doxycycline works, knowing how methotrexate works, and can we understand the COVID-19's inflammatory pathway. Like I said, viral infection is one phase. The disease that causes severity and mortality and morbidity is more a hyperinflammatory disease rather than viral infection per se. So we need to think, okay, are we going to immunomodulate? Are we going to reduce the viral load by giving antivirals? And if there is a scientific basis for that, and I think in the treatment works, if it works, we need to see data. So like I showed you the data of steroids and remdesivir, case series can be very promising, but we do an RCT later, comparing the groups properly, the case series may not stand up to it. And it may not be that the treatment is wrong. Sometimes it may be the study, but we need to look at it in a scientific way. So unless otherwise there is a proper RCT to say the groups are compared in a controlled way, I don't think I can say for certain, okay, that's going to try or not. But we're living in an unprecedented time, dealing with a completely new disease. So if you think this is something that's going to work, it has got a scientific basis, this is a pathway how methotrexate works and blocks the IL-6, you can give it a try. That's your discretion as a clinician. But when everything else has failed, but we do have now a very robust way of thinking, mechanism, and certain things that works. And I can assure you the second wave experiences, the mortality is much less than the first wave for that reason, because we understand things better now. And that's where it should be.
Yeah, that's some relieving news about the second wave. So a few questions from the chat box. One is there's something called chronic COVID or long COVID. Then the other question, in fact, among us pulmonologists, there's actually a debate or fight going on about antifibrotic agents, because the pharma industry is strongly marketing their nintedanib and perphenol. So is there something called chronic long COVID, and what's your view about antifibrotics?
So long COVID, I wish you didn't ask me that question. Viral infection causing a prolonged illness is, chronic fatigue syndrome is one of those things, and there are things like that. There are genuine case reports where the viral load has lasted longer than expected, and they say that genuinely that is a long COVID symptom. Whether they get a viral infection mediated damage to the body, I do not know. Whether they get a cytokine toxicity in the long run, I do not know. So I do not know that answer. But in terms of your second part of your question, which is, sorry, Dr. Bashir, repeat the second part again?
Antifibrotic.
Antifibrotic, yeah. So nintedanib and pirfenidone, especially nintedanib, has got anti-IL-6 properties, and we know that for certain. This was suggested first by Atul Wells, who's the ILD king in the world in Brompton Hospital, in an article in Lancet. This was early in May, I think, April, May, he published his article, A Thought on Anti-Nintedanib. And we can promote that. Like I said, IL-6 is only one inflammatory pathway of the complex interaction between IL-1, IL-6, IL-17, TNF-alpha, interferon. All these are triggers. Whether we're blocking IL-6 on its own is going to give us a result we do not know. Like you used tazolizumab, you used. Case series, did better, but they were heterogeneous. But when the RCT came, tazolizumab didn't fare well. So whether you use nintedanib on its own as an antifibrotic, as an anti-inflammatory in this case, whether that's going to fare well, we do not know the answer. So that's the thing about this thing. Now, for long-term effects, nintedanib, post-COVID inflammatory damage, whether nintedanib is useful, I do not know the answer. And there is a lot of debate. What we've come to a thought process is, we try the steroids, but the steroids are working for post-COVID lung. That's brilliant. Most of them are. If you look at the post-mortem studies, majority of the pathology in post-mortem patients who died of COVID-19 where organized pneumonia changes. And that's why the steroids are working better, I think, in post-COVID lung. But like the CT scan I showed you, where one of the patient has protraction bronchial dilatations, fibrosis setting in, we have given mycophenolase as an agent, and that's where we give mycophenolase. We have not yet seen a patient has a progressive fibrosis, and if that is the case, despite that treatment, yes, there is a role for antifibrotic, I would have thought, there. What we need is a study where look at the post-COVID lung, do a biopsy, look at the pathology, understand the clinical and the pathology, and see what changes, if they have increased fibroblast in them, hyaline membrane deficits in them, and then we can think, okay, what kind of medications we can target to that. We are in the process of, I'm a chief investigator, I've written up a protocol, and we are in the process of setting up such a trial. So we're setting up a trial, see the patients during the COVID, follow them up, see them in the post-COVID phase, do cryobiopsies, and look at the pathology and the clinical features, and then see whether we need to target differently. So, the only way to go forward is to understand it in a scientific way, to how to treat them.
I would like to share some interesting info on that, because how much the pharma industry manipulates things. When in 2015, when Indwelling was launched worldwide, it cost about 1.2, 1.3 lakhs per month initially. Then the cost came down to 60,000 per month. And now in post-COVID times, it's being priced at 5,400, 5,600, 6,000 per month. So that's how they've cut down the cost to promote it. Okay, I think from the audience, if anybody else is interested in speaking out, they have a chance to speak out.
Few questions are left back, no, Jafar?
I think all the questions were answered.
Vaccine is over. Some need.
Yeah, the vaccine was dealt in the talk.
Yeah, it was done. It was done. And this is how this is going to end up, Dr. Liju. I think you have told it somewhat like that. We have to leave it along with the COVID. So one question was, will the colder months will bring the worst form of COVID? Should we, Kerala, fear about a severe form of COVID in December, something like that?
Sorry, Ismail, sorry, repeat again.
Yeah.
Okay.
Yeah.
Sorry,
should we be fearing worst form of COVID in December and all? In Kerala, we are entering the colder months, no? And in Europe also is seen when they become more cold and all this reinfection is coming, second wave is coming, or something like that.
So the logic of the waves, Ismail, is two things. One, everyone, and I think as I said in the beginning, I was warning my colleagues in India, saying you are going to get hit with this thing. Everyone is going to get hit with this thing. And as I said, the WHO is quite right in saying, 60% of the population will get infected. All we'll be doing by locking down is slowing that disease process, that everyone is going to get it. Not everyone, a large bulk of the population is going to get it. So when we ease that, we will see another rise. And the key thing to keep it slow is that we don't overwhelm our resources. So we have to be slow, but that doesn't mean that we have to stop our life. So I think we have to look at the Far Eastern countries who dealt with this. They have experience with SARS and they've been doing extremely well with this one as well. So that's the waves that you would see on and off, and you will keep seeing that waves. And I think that's reality. Winter months, importance of the winter months and the infection. In winter months, especially in the UK context, and I think with the tropical countries, much more I would have thought, is infection. If you have an influenza and COVID, that's a double hit, and they are going to do worse. There is some case reports regarding that, and the mortality is more than 60%, according to those case reports. Again, it's not a big data, but so that's why the fear in winter is if patients who get influenza, which is in the Western world is quite common. That's why every year, especially in the high-risk patients above the age of 50, they're given influenza vaccine freely every year. And if you get influenza and COVID on top of that, your mortality risk is much higher. And that's a real risk. And I think that can be put into any context based on the local infection and what you need to know, your local flora and how things work. And I think that's the thing. If you have two hit on your system, that's going to be not going to be very good.
Another question is, what kind of patients will go for post-COVID lung fibrosis? Can we predict?
We do not know. So that's why I'm putting the study together. Hopefully we will start recruiting as of next month. So I'm trying to phenotype these patients to understand from the very beginning, the moment they come to the hospital, we'll phenotype with everything that we can phenotype them, and then follow them up and see whether we can categorize these patients and predict these are the ones who are going to get it. There is no data for now, but that's the whole point of the study I'm putting together.
Is there any test for long COVID, please? Is there any test for long COVID to predict long COVID?
The only way I think they've done is looking at the viral load. If you have complete viral clearance, you're clear of the disease. And then whether you have inflammation, ongoing inflammation. So when we looked at the patients at 2 months down the line, some patients had ongoing cytotoxic activity like high ferritin, high D-dimer. Then you can assume two things. One, if you haven't cleared viral load, you can call long COVID yourself because the virus is still in you. It should have been cleared by now. The second is you have ongoing inflammatory problem. And if you have a higher inflammatory response, then you need to think, okay, what are the problems you're going to get with it? So obviously, if you have a high TNF alpha in you, you will feel very tired. You'll be feeling quite lethargic. And if you have a high cytokine, you will have the complications like pneumonitis and things like dragging on for a while. So you need to treat those things. There's a high viral load. You need to think, okay, what can I do? Things like remdesivir or favipiravir or something like that to clear the virus load. If it's an inflammatory process, then you think, okay, how am I going to stop this inflammatory process? Steroids or other immunosuppressants, what do you use? And that's the way to deal with it.
From one of the questions from the chat box, how frequently should we take an X-ray or a CT? The serial CTs or X-rays, how frequently should we take?
I'm slightly old-fashioned in that. I think your CT scan and things like that should be based on your patient. Don't go after the CT. Look at your patient. And the patient thinks it's not getting better. Then you think, okay, what am I missing? And then you think about your series of X-rays and CT scans. If your patient is clinically improving, work of breathing is less, oxygen is getting better, there is no reason for you to kind of repeat the CT scan. What I would go is, see them after a month or two, walk them and see if they're desaturating. If they are, then go for a CT scan. Otherwise, just reassure them and get them home. Your patient comes first, CT next.
You have to judge it clinically. That's what you're telling.
Clinically, exactly.
Regarding the test, means initially it was almost 100% RT-PCR. Now we come down to a 10% RT-PCR and everything is antigen test. So how do you view on that?
Antigen testing, that's not my expertise, but Dr. Bashir, I might shy away from it. But having said that, PCR is still the most the best gold standard, I would still think. Okay, a lot of these tests has not been validated in the wider population. The other newer tests, the quicker antigen PCR tests like 30% false positive, false negative, things like that. Antibody testing, I do not know the pickup rate, so I probably wouldn't talk about much. So that's not kind of my area specialty. You're a microbiologist here.
Regarding reinfection, is it actually infection by an entirely different clade or is it a chronic carrier state? That was a question from chat box.
That's a really good question. So there's a lot of debate currently in UK. The second wave we've got actually is from a new Spanish strain, because they have isolated a slightly mutated Spanish strain from Spain. And we know from certain, there is from the animals, there's been infection in Denmark of a slightly different strain of COVID, and 214 patients have been infected with it. And that's why Denmark is now closed and they're not allowed to come to UK, because that strain doesn't need to come in. So if you look at the coronaviruses, generally, they do tend to mutate like influenza does as well. So your reinfection could have been from a different strain. We cannot tell that for now because we need more data, but there is a real risk of it, definitely, yes. But also, like I showed you, the antibody clearance, if it's 3 to 6 months, if you're completely clear, all you are is completely normal person who hasn't got much of in terms of memory, unless you have an adaptive memory that we do not know, is that preventing you from a reinfection? Unless otherwise we do not know. And so we don't know the answer to it, but there is a risk there.
Dr. Liju, you must have noted that the Southeast Asian countries they fare better, means in terms of mortality and morbidity. Is there any specific reason why, means including us Indians, the mortality and morbidity is comparatively low compared to your part, and as well as from the US and Italy? And one thing is that, and regarding the vitamin D deficiency and other micronutrient deficiencies, any relation to the COVID morbidity?
Okay, I will be talking this from my personal opinion, not from a scientific perspective. So I do not know the answers. I don't think vitamin D, anyone done proper study on it. We have done extensive study on vitamin D in TB, vitamin D and bronchiectasis. As you know, there is no data out there to say vitamin D helps. It does have an antibiotic property, but whether it stops COVID, I do not know. My feeling on this is simple logic. South Asian community fared much better because the population is much younger. It's a younger population. If you look at the countries that actually died a lot more, it's either two reasons. One, they didn't have the resource, just like the Americans and the Brazilians. In terms of Lombardy in Italy, where they died, was again lack of response and a higher aged population. It's exactly the same in UK as well. In UK, we have a higher death rate because of the aged population who died. Nearly 50% of the death in UK was from patients in nursing home, elderly patients in nursing home, almost 50%. So the death because of the aged population is much higher here compared to India, where there's a younger population. And I think that's the biggest difference. Other factors, I don't know.
Any role for routine use of heparin in Kerala? Depending on the D-dimer level, we are routinely using heparin for the during the initial period. Any role for the use of heparin and NOACs as a continuation for 6 months? Any role?
No, I think that's a way to do it. So if you had higher D-dimer, D-dimer only means you got an inflammatory state, but the D-dimer levels are very high. Sometimes we were seeing levels, so supra levels I've never seen in my life. So obviously thrombosis is a definite risk, especially microembolic disease. What we do is we treat the initial phase. Once the patient gets better, if they're no longer hypoxic, we stop them. But like I said, if they have ongoing hypoxia post-COVID, after a couple of weeks, then we investigate it. We look at the lung disease. If they have no reason for VQ mismatch, then we give them, and they are still hypoxic, then we treat them as microembolic disease with a prolonged, almost a year or more, probably a lifelong anticoagulation with NOACs. That's what we tend to do now. And we have found a lot of patients like that, completely normal CT scan. They are hypoxic on exertion. And sometimes even we do VQ and SPECT scan, there is not much to see, but definitely they are hypoxic clinically. So we're treating them as microembolic disease with NOAC. That's that.
Is there any COVID-related specific ECG changes other than ACS? Any idea? That was a question.
Not that I know of. Myocarditis and heart failure is a common thing in severe disease, especially those who end up in ITU.
There are conduction changes also, affecting the conductive system also. What is the discharging criteria for patients who repeatedly become positive after weeks, even after an acute illness is settled? Persistently positive patients, what is the discharge criteria?
We keep them in till they get better. If there's been severe illness, we keep them in usually.
Yeah.
We keep them in, so if they're really well, we get them out and in social isolation till they become negative. So they're not mixing with other people and giving the infection. That's what we do here. If they can't be managed on their own at home, we keep them in the hospital as long as it needs to be. But if they are really well, they can manage on their own and they can be isolated at home with help at home, then we discharge them to the community. That's what we do.
How bad is the second wave of infection in Europe? Is it as severe as the primary wave?
It's slightly worse than primary wave.
Is it because of the bad weather? Is it something like that?
A lot of factor. I think whether I do not know, Ismail. So, but I think one, people have had enough of the lockdown, so people are getting back to trying to get back their normality. The life is going moving, and the social distancing and things like that. The hygiene measures and everything has been broken down, and that's the main reason. Secondly, like I said, it's moving to so London is still quite less affected. If you look at UK, we only have 40-50 admissions. We in peak we had about 200 admissions or so per every time. But now what's hit is more north, so it's actually just moving places to more populated areas and things like that. So it's just the fact that the life people are trying to get back to normality, breaking down those control measures, and just getting it spread over all the place. One, and then we are testing more intensively than before. So previously, there's a good chance that we actually didn't test the population properly, so we didn't get the numbers accurate. And I think that's probably around the world as well. I don't think anyone is getting the numbers accurate.
Dr. Liju, one more question from me. Is there any load for vitamin C and zinc, which is widely prescribed in India? And another question is, you are telling now, once the 60% of population is exposed to this disease will get converted from its epidemic stage to an endemic stage, something like that, no? So we can live better with the disease, and the presence will be lesser, extent will be lesser.
Yeah.
So when it will happen, how can you predict it like that?
There's no way to predict it, Ismail. It depends on the countries. If we just like like Boris Johnson at the start of this in February said, we're just going to go for herd immunity. The idea was to get everyone infected. Yeah. Okay. So if you open it up, yes, we can get it very quickly. But the key thing is, we will have a huge amount of mortality. For look at the Spanish influenza data, just in India, nearly 10 lakh people died of Spanish influenza. So the mortality will be high, not because of the disease itself, it's because we can't provide them the care. So there's no way to deal that. So I think this is going to go for another year or two. We're looking well into next year, end of next year, before things will slow down. Because the population needs to be exposed slowly, otherwise there will be a huge amount of mortality. And that's where it's going to be. So I think the end will be slow, but we'll get there in 2 or 3 years' time. It's going to be slow. I don't think it's going to come in a year or so, and the vaccine is not going to change. I don't think that's going to happen. But that's
they're telling vaccine will be available by November this month, and Oxford vaccine will be coming and all. In the UK, no, nothing like that.
Okay. Now they're talking in January, they're talking moving milestones. This is all media. In terms of vitamin C, there is a small data out there with vitamin C saying slightly better. But again, it's not an RCT. We don't know the effect of that. Zinc, I have no clue. Zinc does in this inflammatory response and pathways. So I do not know.
Anyone else from audience? Any other question from audience?
Well, I think it's time to wind up.
Yes.
And one last question, the real factor which is going to settle this pandemic, is it herd immunity? Final nail on the pandemic coffin.
I may not say it's herd immunity, but I think yes. Once the mass population is infected, we have some sort of innate immunity response there. I think it will slow down. Until then, you will see it's going through. Herd immunity is slightly different, isn't it? So we get herd, we become immune as a herd, we become completely immune. I don't think we will become immune that long, but yes. And the good thing about the vaccine, bringing back the vaccine, again, is if you have a vaccine, it's not going to stop it. What it's going to do is, it'll give that immunity if we can mass immunize people, that will slow things down just like influenza. It won't get it away, but it'll slow things down, just like having infection. So one of the other things has to work. So either it will be a vaccine in the end of next year that will help us, or this infection spreading that will help us to end this pandemic.
Thank you, Dr. Liju. You really did a good job, and you really did justice to your whatever you intended to do. Thank you from my part.
Thank you, Dr. Bashir.
Yeah, it was an excellent session on a Saturday evening. I think it's afternoon in UK, and you have found a big time to spend with us. I'm inviting Dr. Dani to give the vote of thanks Dr. Danny?
Yes. Dr. Liju, it was a wonderful talk. I thank you very much. I thank you very much for taking this time off. Sorry, some connection issue. I thank you, Dr. Liju, for taking this time off to help us clarify our doubts. And I think above everything, you have really set as a role model. I'm really happy to hear that you're a clinician as well as a researcher. And you've actually put forward various studies and not only dealt with their conclusions, but at the same time analyzed for us how much we can take what the study says. So I guess this kind of approach to medicine is the actual way how we should distinguish ourselves from traditional people who practice medicine. So in all aspects, this was a modern medicine class, and I thank you very much. I thank everyone for taking their time off on Sunday night for this talk, and I invite all of you again next month for similar such talks. And thank you once again, all Dr. Mohammed Ismail, Dr. Jafar Bashir, Dr. Naseem, for making this opportunity for all of us. Thank you. Shall we wind up, Ismail sir?